Nick, looking at this case that you're about ready to start, you wanted some insight on, make sure that there's no snakes in the grass associated with this case. She's a late adolescent female looking to mostly correct the lower anteriors. And as with any case, always start with diagnosis: molar class 1, canine class 1. These are always the more straightforward cases to do with Invisalign, not because Invisalign can't move back teeth, but if we don't have to move back teeth, we increase the predictability of the result. With that said, anytime I have a situation where there's a potential Bolton discrepancy, I always want to think in the back of my mind that I want to over-treat the anterior so that I don't end up with a posterior open bite, which is more of a posterior or relative posterior open bite as a result of lack of tracking with the anterior teeth. And it looks like you built in a good amount of overjet, excessive overjet here. This is always easier to close than to have inadequate overjet, which means the door doesn't fit in the door frame, which causes a relative posterior open bite. Again, we talked about this last week. Posterior open bites due to Invisalign isn't because the Invisalign trays are intruding the posterior teeth, although there's some truth to that. When you have a 1 to 2 millimeter posterior open bite, it's not because of the trays. It's because of anterior interference due to lack of tracking. So whenever I have these deeper bite cases, I always want to build in excess overjet and maybe even create what's called a negative overbite. And what would that look like? Again, this is for deep bite cases where the patient's class 1. I might do something like this. So a negative overbite would be something like that. That's a lot of intrusion. As we can see in our tooth movement table here, it's almost 3 millimeters of intrusion. Let's see what movement assessment. So we're in the blue. Yeah, once we hit 3 millimeters, then it becomes a difficult movement. I'd feel very comfortable at this level here. This degree of intrusion is going to require really good attachments posteriorly, which you have here. Some might say you want to replace one of these with a 4 millimeter rectangular attachment so that the tray doesn't want to fall off the tooth. As we're providing an intrusive force anteriorly, there's a reciprocating extrusive force, not extrusive to the tooth, but extrusive to the tray. So having these buttons back here is very helpful. I would feel comfortable with this case leaving these optimized attachments. These attachments will act as a reinforcement for the intrusive force anteriorly, but these optimized attachments are meant for optimizing the movements of the individual teeth. In this case, these are kind of rotational attachments. One of the ways we correct a class 2 bite, not saying this is a class 2 bite, but we rotate the upper molar, as the upper molar is very oblong or rhomboid in its shape, that if you rotate it in this dimension, counterclockwise, we decrease the arch length. And it looks like they did that here. And I'm thinking that might actually work against you because you have the Bolton discrepancy. So what I might do is actually have them make this unmovable. There's no reason we need to rotate that tooth to that degree. I might even do the same here. Of course, it changes the aesthetics. But what would happen here is we're actually going to have more overjet in the anterior because our arch length isn't decreasing. Again, class 2s are normally corrected, and this is true with braces, with what's called a mesial out rotation or clockwise or counterclockwise rotation of the upper first molars or the upper sixes to decrease the arch length, which then decreases the potential overjet in the anterior because we're able to retract backwards as the arch length decreases. So we kind of have the opposite problem here. We have a Bolton discrepancy with a class 1 molar relationship. So by making this unmovable and then maybe tightening up these teeth here to make them a little bit more aesthetic. And you can move this, by the way. So let's make this movable again. So you could do like a distal hinge rotation. That's rotation, so let's go distal, something like that. You're not changing the arch length. You're helping the aesthetics in this area. And you're increasing how much overjet potential you have. So what this would possibly do is decrease the amount of IPR you would need on the bottom. Make movable. So what I'm using the distal hinge rotation rather than pure rotation, which is somewhat maintaining the arch length. So that looks better there. Now let's bring the lower back in. Look how much more overjet we have now. And you'll be able to compare the two when you go to, when I do the live. Actually, I'm going to have you do this. So I'm going to X out of this. I want you to do it and then hit live update and then compare and contrast what they had for overjet with and without these subtle changes here, which is increase intrusion here and then decreasing the rotation of the upper sixes. That's a lot there, so I might actually consider dialing back or eliminating the IPR. My gut tells me that this case can be solved without IPR despite the fact that the Bolton is there. Maybe you reserve the IPR for the second round or just dial back how much IPR you're doing. I actually like 0.3 here because of the shape of this tooth. It's triangular. I would rather do kind of 0.4 here and have it be 100% on the distal of the lower laterals. To do that, you're going to have to use like a one-sided disc rather than indiscriminately removing all of the enamel between both. This one's less so I'm probably just going to go to 0.3 on that one. Midline looks good, so we probably want to even these out. These straight contacts are really hard to do IPR on, so sometimes I will eliminate that and eliminate that. Still a lot of overjet. Again, we're not going to see this clinically because we're not going to get 100% of this intrusion, but by decreasing the rotation of the molar, we increase the arch length. I think we're in a much better situation here. I don't think you're going to need IPR here. I would skip the IPR for this first round unless you need to do it for aesthetic and or hygiene purposes. And I would set it up where you really maximize the intrusion of these, get it right up to the 3 millimeter mark, somewhere in that range. And then make sure the patient's wearing their trays a lot. Deep bite cases really require very significant compliance, in great part because intrusive forces, although are possible with Invisalign, require a high degree of compliance. You can see we have almost like an exaggerated open bite. We're not going to see that clinically. And lastly, I might intrude these lowers too. Something like that. And you had asked about a periodontal consult prior to ortho. I don't think there's anything wrong with that, but one of the things I'll look at is the direction of the tooth movement in relation to the alveolar housing. You can see how much tissue there is. So if we look at this right here, anything facial to 24 and 25 there's a lot of tissue and bone here. So you're not really going to expect any recession because of how much bone and tissue are facial to that surface. One might say 26 already has some recession and we're going to be bringing it facially. I would agree. But just kind of keeping in mind that just sending patients to the periodontist and expecting them to magically answer whether or not there's a high risk here tends to be a very misleading part of the Invisalign or clear aligner therapy world in the hands of the GP. What I mean by that is 99 times out of 100, you're going to send this patient, they're going to say, go ahead and do the ortho and then we'll see how the recession looks after. And I think this particular case, you're probably going to get that. With that said, I think it's a good exercise to go through, but if you do 10 of these and you get back the same answer from the periodontist, I would encourage you to be more comfortable with making the decision when a patient needs to see a periodontist versus doing it just to be safe. You know, we should be smart enough as general dentists to understand when it's needed versus, just kind of screening. You know, it takes a lot of time out of a patient's day, and the periodontists don't really like when they get 1,000 consults from a general practitioner to do something that's pretty straightforward. This might fall into that category. With that said, I think this is a great one to send because she has a very thin biotype, which is the other important aspect to this. What I might do is provide some additional facial root tip or buccal root tip. That's the crown tip. This one here. With the goal being we want the cervical aspects of these teeth to potentially line up with the cervical aspects of the laterals. So then what I might do is actually do some lingual root tip. On these laterals where I'm more likely to get recession. This is a very hard movement for Invisalign to do, so I'm going to overshoot it. But if your case looks something like this, I would be very surprised the patient would need anything, and we can always graft after. So there's nothing magical that the periodontist would do prior to the orthodontic treatment plan other than say something to the effect of, please move these teeth in a periodontally sound situation or manner. So I would feel very comfortable with that being your final clin check. It looks crazy, but that's what deep bite cases need. They need something like that. Negative overbite is what we call this situation where we have an anterior open bite. And then excess overjet from this angle. To get there, you might want to lock some of these teeth, remove the rotation of the upper sixes, and then just kind of dial everything else in. Lastly, what I might do is actually extrude some of these posterior teeth to help resolve the anterior open bite. I wouldn't do that here. But sometimes the answer to fix the anterior open bite is to extrude the posterior teeth so that the jaw closes a little bit more prematurely, which helps to resolve the anterior situation. All right, let me know how it goes. I'm going to X out of this because I want you to go through all these changes yourself so that you get the experience. Take care.